Welcome to the Anesthesiology Journal podcast, an audio interview of study authors and editorialists.
Hello, I'm Jim Rathmel, professor of anesthesia at Harvard Medical School and chair of the Department of Anesthesiology, Perioperative, and Pain Medicine at Brigham and Women's Hospital. I'm one of the executive editors for Anesthesiology, and you're listening to an anesthesiology podcast that we've designed for physicians and scientists interested in the research that appears in the journal. Today we're going to talk with the senior author of an original research article and the author of an accompanying editorial that appear in the May 2021 issue. With us today is Dr. Amy Vinson. Dr. Vinson is Senior Associate in Perioperative Anesthesia in the Department of Anesthesiology, Critical Care, and Pain Medicine at Boston Children's Hospital and Assistant Professor of Anesthesia at Harvard Medical School in Boston, Massachusetts. Dr. Vinson is the senior author on an article that appears in the May 2021 issue of the journal, and it's titled Burnout Rate and Risk Factors Among Anesthesiologists in the United States. Dr. Vinson, thank you for joining us.
Thank you for having me, and thank you for highlighting this project. We are very excited about the results and believe it will genuinely empower positive change within the profession.
We also have with us today Dr. Steve Hyman. Dr. Hyman is professor of clinical anesthesiology at Vanderbilt University Medical Center in Nashville, Tennessee. Dr. Hyman authored an editorial that accompanies Dr. Vinson's original research article, and it also appears in the May 2021 issue of the journal. It's titled Burnout, the Other Pandemic. Dr. Hyman, welcome and thank you for joining us.
Thank you for asking me. I'm humbled and honored to be here, and I'm very glad to have gotten to review Dr. Vinson's paper.
Dr. Vinson, congratulations on the publication of your study. Let's start by setting the stage for your study for listeners. Physician burnout is widespread across medicine, and it's been linked to poorer physician quality of life and reduced quality of care. What do we know about risk factors for burnout and its prevalence among anesthesiologists?
Well, thank you very much. First of all, I want to thank the entire team of co-authors and research assistant who put this project together. Dr. Anushka Afonso, Josh Cadwell, Steve Staffa, Dave Zurikowski, and Julian Post. I can say confidently I have never worked with a more synergistic team than this one, and I look forward to future projects together. Since the first major study of physician burnout was published in 2012 by Tate Shanafelt and his colleagues, it has been a growing area of research and concern, frankly, for all the reasons you laid out: poor quality of care, reduced career longevity, decreased engagement, as well as a host of personal health factors and mental health issues. I think it's important to remember, though, that burnout is one of a number of symptoms of unwellness within our profession. It is certainly the easiest to study and quantify, though, and I think that's one of the big reasons why it tends to be what we talk about when we talk about metrics of physician well-being. The other things like depression, suicidality, substance use disorder are also prevalent within the profession, but inherently terribly difficult to accurately assess for a number of reasons. When you bring up the topic of risk factors and what we know about the prevalence in physicians and in anesthesiologists, what immediately jumps to mind are personal risk factors. We want to know who is at risk for burnout. Is there an age, a gender, caregiving responsibilities, being a member of a disenfranchised or marginalized community? And really, the data regarding these demographic factors has been scattered depending on the data set in question, their assessment tool, their study population. So what has become more and more consistent and highlighted profoundly in our data set is the role of the work environment on burnout, specifically how supported one feels in their work life.
So you conducted this study to improve our understanding of burnout in anesthesiologists specifically. You surveyed members of the American Society of Anesthesiologists in March of 2020. We're going to discuss that time frame later. That was the peak of the first wave of the COVID-19 pandemic in some parts of the country. What tools did you use to measure burnout, and how was the study conducted?
Yeah, you bring up a really good point. That was not my preferred timing for a survey study, but I don't think any of us saw the peak of this coming quite that clearly. We used the Maslach burnout inventory, and we used the version for people in the health services industry. The Maslach burnout inventory itself has been used since the early 1980s when it was developed to study burnout. It is broken into three major domains: emotional exhaustion, depersonalization or cynicism, and low sense of personal accomplishment. It is a highly validated metric. It is a 22-question survey that uses Likert scales for each question, and they fall into those three domains. Beyond that, in the burnout literature in physicians, there are some typical definitions that have been used in the larger studies, and that's what we went with to classify our people that we consider at risk for burnout. So to define at risk for burnout, we looked at people who scored at a threshold level for either emotional exhaustion or depersonalization or both. But beyond that, we wanted to look at something a little bit different as well, and it was something that hasn't really been done a lot in the burnout literature, and not to my knowledge at all in the physician burnout literature, and that's looking at people who have what we consider to be the full burnout syndrome. And we defined that as people who achieved a threshold level on those Likert scales in all three domains, so emotional exhaustion, depersonalization, and a low sense of personal accomplishment. And that's in line with the definition of burnout syndrome from the World Health Organization, and it's also one of the things that Christina Maslach herself has spoken about in prior talks at the ASA, in fact. Beyond these questions, there's only so many questions you can ask in a survey before people get survey fatigue and don't finish the tool. So we had a handful of questions remaining to gather demographic and practice factor data to really look at and inform associations between burnout and personal factors and work factors, and make sure our results can actually be truly actionable to impact change. We sent it as a formal email communication from the ASA after it was approved by the executive committee and leadership with the ASA. It was also endorsed by the Committee on Physician Wellbeing, which, in full disclosure, I'm the committee chair of. We plan to send 3 follow-up emails, 1 a week, but ultimately we cut out the last reminder because just the burden of email communication was becoming almost untenable at the end of March when the surge of COVID was on the horizon for many people and perhaps even already there for others.
So what did you learn?
So this was the largest targeted survey of anesthesiologists burnout to date. Prior data sets published, the large ones of physician burnout had about 400 participants each. Recent subspecialist data sets encompass around 1,000 participants. Our survey data set had about 4,000, almost 4,000 participants. We learned that 59% of respondents were at high risk for burnout, and nearly 14% had full burnout syndrome. Breaking that down into those 3 domains, 53% had emotional exhaustion, 37% had depersonalization, and almost 26% had low sense of personal accomplishment, which was interesting because that tends to be the domain that physicians do the best at. We looked at the independent risk factors for both high risk for burnout and burnout syndrome. And one thing jumped out right away, and that was responding to having little or no support at work. If you responded to the question, how much support do you have at work, with either little or no support, your odds ratio of being at high risk for burnout was more than 6, and your odds ratio for having the full burnout syndrome was more than 10. So it was a massive factor in your risk for burnout. Do you feel supported in your work life? There were other factors as well, but nothing that quite jumped out this much. Some things that increased your risk of having high risk for burnout included working more hours, being a member of the LGBT community, staffing shortages, not having any support at work, not having a work confidant, and age less than 50. One interesting thing we found was that English as a second language seemed to actually be protective for burnout in this group. When we actually looked at the full burnout syndrome, again, not having support at work was a massive factor. But so also, to a smaller degree, was not having any support at home, again, younger age, being in private practice, lack of a confidant, and staffing shortages.
Now, you surveyed almost 27,000 anesthesiologists, or you contacted that many, and only 13.6%, or just about 4,000, completed the survey. Does it give you any concerns about the validity of the study as a whole when you have that low a response rate?
We certainly want to have as high a response rate as possible, and we certainly had the constraints of the pending COVID surge, but it was certainly a large enough population to power the study, but you have to worry about selection bias when you have a small respondent percentage. To address this, we compared our respondent population to the target population at the time and found quite similar demographics with available data from the ASA. Furthermore, this was not far off from other prior large data sets of physicians in burnout. Finally, the most salient takeaways from this data are not the incidence rates of burnout. On its own, those numbers are not particularly actionable information. The most important takeaways are the associations with personal and practice factors, particularly the sense of support in the workplace, because those are the things that can lead to actionable change.
So if you were to pinpoint one thing in the workplace that is actionable and you could change, or maybe it's a collection of things, what sorts of things would you recommend to anesthesia groups or leaders of anesthesia groups or hospital systems that they address?
I think the most important thing is to open communication lines, particularly between leadership and the people doing the work. Querying people about if they feel supported in the workplace or not is important, and that gives you a sense of the pulse of your department or your group. But it begs the question, what makes people feel supported in the workplace? It's a tricky question because, if you look at the research, there's a number of factors that make people feel supported. A lot of them have to do with leadership. But, the group out at Stanford that has done a lot of this burnout work and Mayo, they always say that, if you've seen one group, you've seen one group. So I think what's important is that you open up those communications and you ask the people in your group or your practice, what makes you feel supported? What makes you feel not supported? And really understand that about your group and then make change from there.
What were the limitations of your study?
Well, we already touched on the response rate. I think people were really prioritizing their email ingestion in March of 2020 and in probably a healthy manner, quite frankly. A lot of people probably deprioritized an extraneous survey. I don't think that the COVID surge had fundamentally changed rates of burnout that early on. And when we looked at trends across time, meaning across the three sort of boluses with the email reminders, we didn't notice a change in burnout rates as the month went on. But the number of questions is also a limitation when you use the full Maslach burnout inventory. As I said before, it's a 22-question survey, so that doesn't leave you a lot of questions before you've really hit that, what I consider a maximum of 35 questions in a survey, and people start dropping out. Believe me, I would have loved to have all respondents answer 100 questions and really get some more granular data, but that's just not going to ever happen.
Dr. Hyman, I want to turn to your editorial. It also appears in the May 2021 issue of the journal. The editorial is titled Burnout, the Other Pandemic. You do a terrific job of putting Dr. Vinson's article into perspective. Where did this term burnout originate?
Well, the first time that burnout was really described in an article was in the 70s by a psychiatrist named Herbert Freudenberger. While clearly probably there was burnout way before the 1970s, this was really the first time that it was actually put on paper. These were not studies, but they were more in a case report format in some of the more obscure psychiatric journals. But he was describing what was going on in a series of child psychotherapists that were working in free clinics in New York City. And he was noticing in those people that they had emotional depletion and disengagement. And, we talk about disengagement sometimes as being synonymous with burnout, and I think it really is. And while we don't use the word emotional depletion anymore, I think we all know that emotional depletion is really synonymous with emotional exhaustion.
Now, Dr. Vinson touched on some of this, but What exactly is burnout, and how's it measured? Maybe you can expand on her comments earlier.
Well, after Freudenberger's papers in the 1970s, several researchers came up with different ways to monitor burnout. But finally, in the early 80s, Christina Maslach came up with her Maslach burnout inventory. Her opinion about burnout was that it occurred because of an imbalance of personal factors and work or situational factors. Some of the personal factors would include certain demographics like age, marital status, educational level. Some of the other personal characteristics would be psychological characteristics. For example, does the individual have hardiness or resilience? And finally, what she felt was contributory to these personal factors were levels of expectations about jobs. When we go to medical school and stuff like that, we have a sort of a vaulted expectation about what we're going to find. And then when we actually get into the practice of medicine, we find out it's not like Ben Casey or Dr. Kildare or some doctor show on television. There are lots of things that are really difficult to deal with that are not like public expectation would be. And if we've had our expectations on a vaulted level, then we find out that it's not quite that way. We can be very disappointed. The other thing that she talks about in terms of this imbalance is what happens in the workplace. Of course, there's going to be characteristics of the job. For example, we all sort of know that there are going to be risks and stresses associated with being an anesthesiologist. But when we actually look at the job that we're doing at the place that we're doing it, there can be characteristics of working at that individual institution or at that hospital that can cause stress and cause people to get imbalanced. I think that the thing that to me is the most difficult about all of this is that the imbalance that occurs may not happen in another person. And particularly, I think when people are older, they've learned how to marginalize their stresses. And so they're not as much at risk for burnout as what the younger population is.
I want to read a bit from your editorial. You tell readers, being a physician is in and of itself stressful, but working at a job where more is being demanded with less given in return, for instance, financial reward or sincere appreciation by the employer, can result in a negative spiral. Can you tie that with some of the finding in Dr. Vinson's studies and describe some of the manifestations and consequences of that negative spiral?
After I heard Dr. Vinson talk about the different findings that they had, I wanted to focus just on the piece about the workplace support. I think that we kind of forget that people will need some kind of workplace support. And I'm going to come up with an example that I've actually seen in our department. Let's say, for example, we have a badly behaving surgeon, and we've put the youngest, freshest anesthesia attending into that room, and there's a bad outcome. So already, the young anesthesia attending is being stressed because he's in a difficult room, and the badly behaving surgeon is really giving him the business. This young attending may also not feel like he has a colleague or mentor that he can bounce things off of and talk through his problems. Subsequently, he may be focused on his bad outcome from his other case and may continue to make more mistakes, become more depressed, and ultimately leave the job. If he's lucky, he might go to another job that's not as stressful. But chances are, and some of the literature from other papers have pointed out that there are huge numbers of people that are considering leaving the medical profession within the next couple of years. Also, I think that one of the things that has come out in various papers is that because of the stigma attached with psychological disease, that a lot of these people who become depressed may be reluctant to go get help for their psychological disorders. So instead of getting help and getting cured, they'll just leave medicine altogether, which also compounds the problem of being shorthanded at work and not having enough qualified people to do different things.
Now, this survey took place right at the very start of the pandemic, as we already talked about. How do you think the pandemic impacted anesthesiologists and burnout among them?
In January, I looked through the literature to see if I could find an answer to this question, because almost certainly you feel like the stress of dealing with the pandemic has increased the level of burnout. And there were a few articles, not really great articles, that suggested that was indeed the case. I can only use some of my colleagues as an example. Now, because I'm older, I was a little bit shielded from having to go get on the front lines of dealing with COVID patients. But some of the people, both in the anesthesia department, a lot of the residents in different departments like orthopedic surgery and general surgery, got pulled out of their regular rotations in the operating room and had to go work on the floor doing primary care of some of these people. And indeed, some of the attending type anesthesiologists had to do the same thing. And I think that as anesthesiologists, we're frequently called on to do things that other people don't want to do or don't feel comfortable doing. But because it's not in our repertoire of things that we do every single day, it can also cause stress for us. I think that if this study were repeated at this particular time, or at least a month or so ago when the numbers were still pretty high, I think we would have found that there was a lot more burnout and a lot more dissatisfaction and imbalance than there was prior to the pandemic.
What's your personal formula for minimizing your risk of burnout?
For me, I have not worked 5 days a week for about 20 years. I've realized that if I worked more than 3 days a week, I was kind of grouchy and difficult to deal with. So about the year 2000, I started working 3 days a week. And I went back to school and got a master's degree in music. I had always decided that I was going to start working on a bachelor's degree when I was 50 years old and do that in piano performance. So instead of doing a bachelor's degree, I was able to start out with a master's degree. So a lot of my time is spent getting ready for concerts and getting ready to play with orchestras and things like that, which is certainly a big distraction from practicing medicine.
Dr. Vincent, again, terrific work. I want to ask you that same question. What's your personal formula for minimizing the risk of burnout?
It's a really good question, and I like that you ask what the personal formula is for minimizing burnout, because it's different for every person. Before I answer it, I do want to kind of echo some of the things that I've said and that Dr. Hyman said. I want to make it abundantly clear that I believe that the individual physician does carry a responsibility to optimize their own well-being and optimize their own resilience, but that the organizations that they work within have an even greater responsibility to create cultures of support in which employees have no barriers to full engagement and fulfillment, and where anyone who needs any kind of help accesses it. Period. I mean, you brought up before mental health care and that sort of thing. Removing the barriers to accessing those things is critical going forward. That being said, you asked me about me personally, and from what I've seen, the lifetime incidence of burnout in physicians is probably somewhere around 800%. And by that, I mean that it's cyclical. People start getting burned out, and then they restore, and then they start getting burned out, and they restore. Recognizing those signs earlier when you can do something about it and you're not trying to turn the Titanic when you've hit an iceberg is important. So education and intentionality is important. People need to be able to recognize their early warning signs for burnout. For me, my big early warning sign, my big early red flag is sarcasm. If I start making sarcastic jokes, whether it's at work or at home or what have you, it sets off something in my mind to say, uh-oh, what's going on? Something's going on. You need to take some time for yourself and be really intentional about self-care for a little while. Other people around me are not going to notice it because I'm telling jokes, and sometimes I'm funny. And so people are laughing, right? You're making sarcastic jokes. But for me, it's a red flag. I know that's my early warning sign. People need to recognize what their early warning signs are for burnout. Then if I see it's happening, I become tenacious and even more intentional about self-care. That often means firming up boundaries, prioritizing work and home tasks, saying no a little more. I also, much like Dr. Hyman, I engage in things that feed me personally. Family time is very important to me. Music is incredibly important to me, whether I'm playing piano or singing or playing guitar or just listening to music. Fitness is important. Little home improvement projects. Look, I'm sure I'm not the only anesthesiologist with a slew of hobbies, but they're important, and they inform the well-rounded person that you want to be and that you want to be for your family and that you want to be for your patients.
So what comes next for you and your research group?
There are some aspects of this research that we are very excited about, many of which listeners have already probably inferred from this discussion. One that we haven't talked about a lot is we want to investigate some of these risk factors a bit more closely, particularly the burden on the LGBT community. We found that they had an odds ratio of greater than 2 for being at high risk for burnout, and I don't know why. We want to delve into that a little deeper and see if we can offer support there, because that's also a community in general that has very high rates of mental health concerns and suicidality. So we want to look into that a little deeper. We want to see how the data differs post-COVID and among trainees. We surveyed attending anesthesiologists. We want to also look at trainees in a similar way. We want to also see if there might be an easier way to assess change without cumbersome survey instruments or with using shorter instruments. But most importantly, we want to see what makes people feel supported in the workplace. If that is the singular question, do you feel supported in your workplace, that predicts disengagement and burnout, we want to know what on earth makes people feel more or less supported. This is also in line with a lot of the work being done by a few of the ASA committees currently. So I'm hoping we will soon see a real coalescing around a unified theme of supportive culture as both a physician well-being and patient safety guidepost.
Terrific. Well, as a department chair, I eagerly await your findings, and I can tell you that how important that question is, asking people what makes them feel supported and finding a way to provide it. It's a tough thing to do. I hope today's discussion will lead many of you listening to read this new article that appears in the May 2021 issue of Anesthesiology, where you can learn more about burnout among anesthesiologists in the United States. Dr. John Wanderer from Vanderbilt and I also created an infographic that appears in the same issue, and it's titled The Fire Among Us, Burnout in Anesthesia, where we highlight the primary findings of these articles. Dr. Vincent and Hyman, thank you for joining me today and for the terrific explanations.
You've been listening to the Anesthesiology Journal Podcast, the official peer-reviewed journal of the American Society of Anesthesiologists. Check anesthesiology.org for an archive of this podcast and other related content.